Happy evening to all. I wholeheartedly welcome you all for the webinar on Dual Mobility Cup. Before we begin the session, today is a very auspicious day for all of us. It is happy Makar Sankranti to everyone. And I wholeheartedly thank you, our special guest for today, Mr. Andrew Fierra, my boss, who was my mentor in the France. And thank you very much, Fierra, for accepting my request for the today's webinar. And let me take an opportunity to introduce today's our guest speaker for today. And Mr. Fierra is a hip and knee replacement surgeon working at Clinque Du Parc, France. And he carried out more than 1,500 ligament repairs and nearly 4,000 arthroscopies of the knees. And Mr. Fierra did more than 1,500 primary and revision total hip replacement surgeries and more works on the dual mobility cup. And he also performed more than 1,000 primary total hip knees and revision total knees, totally more than 8,000 surgeries in the hip and knee surgeries. And thank you very much, Fierra. I once again welcome you for the today's wonderful session on dual mobility cup and its current indications, functional outcomes. And thank you again. Hand over to Mr. Fierra for accepting our webinar.
Okay, so
you can share the screen.
Okay. That works? Do you see my screen? Yes? Okay. So thank you very much for your kind invitation, and thank you in part to Dr. Naidu, Balaraju Naidu, who was worked a lot to organize this webinar, and I hope that it will be at the level he expected. So thank you very much.
Thank you very much.
You know that dual mobility cup is a French specialty. And the question we can ask in France is why it has become a French standard. And probably now it's widely used in the world, and we trust that in the future it will become a global or mondial standard. Okay, so my disclosure, of course. Why this debate? Remember of the debate. Total hip arthroplasty is a compromise between mobility, stability, longevity. But now we have to operate it on more and more young and active patients, more demanding patients. And they wish to do training, to do sports. Which sports? That depends, of course. And with very demanding patients, now dislocation, the rate is close to 1 to 5%, is no longer accepted. But in the same time, these demanding patients ask for a very high longevity for the implants. So could we achieve all these parameters, stability, mobility, and longevity? So that's the question of the primary THA now. We know that dislocation is the main short-term problem, as we can see in all the registries. And it is the first reason for revision in the first 4 years, depending to the first indication. And we can see that in the Swedish hip register, the oldest one, and in the British one of the NHS, we see that revision for dislocation during the first year is 0.4% in the Swedish registry. But 1/4 of the revision during the first year is due to dislocation. And we have the same results in the British registry. 20% of revision during first year for dislocation, and stability is the reason of revision for 2.32% in the first year. What are the dislocation mechanisms? Impingement and translation. Impingement, it is due to a conflict between most of the time the neck of the implant and the acetabulum. It can be between bone and bone or bone and soft tissues. And in particular, we can watch this problem for obese patients. On the other hand, translation is another mechanism of dislocation due to weakness of the muscles. So we have a decoaptation of the implant, and it is mainly secondary to age or multiple revision or neurologic disease. And we can observe this mechanism when we raise from a sitting position. But most of the time, the dislocation mechanism is a mixed one, impingement and translation. And for example, when we raise from a sitting position. So to avoid dislocation and for impingement risk, we can increase the jump distance. It is the theorem of Masse and Wagner, and they show that the jump distance is the distance that needs the head to go out of the shell of the acetabular part, and it depends on the diameter of the head. With a 22 head, this jump distance with a cup of 52 millimeters is 12 millimeters. With a 28 head, it is 22 millimeters. With a 36, 27, and with a dual mobility, because we have to consider that the insert on the head is the head of this prosthesis, and then the jump distance is very high, about 40 millimeters. So dual mobility increases the jump distance and delays impingement, and the mobility is good thanks to the recruitment of two phenomena: the movement of the head into the insert and then of the insert into the shell. So that gives a very large range of motion, and most important, delay the contact between the neck and the insert. It's the introduction of the prosthetic impingement theorem of Nevelos that we'll see later in this presentation. Dual mobility is not a constraint cup. It's very important to consider that. A constraint cup is very useful when there is a risk of decoaptation of. It is an anti-translation system. It's completely different. And dual mobility cup is completely different than tripolar concept. It is an American one. That's true that there is a bipolar component very close to dual mobility system, but then it is blocked in a constricting system into the liner and then the metal shell. So that's completely different. And of course, because of the addition of mechanism, there is an addition of concerns. The most important one is the risk of extraction of the shell from the bone. It's the type 1 in this schema. The results are completely different if we consider constraint cups, tripolar cups, and dual mobility cups. Against dislocation, of course, results are close from tripolar and dual mobility at the end of this table, but the risk of revision is higher. First, with the constraint cup, about 20% at close to 5 years, 10% for the tripolar cups, and only 2 to 8 with the dual mobility cup. So we can see that the freedom that offers the dual mobility cup is probably the best compromise between the constraint cup or the standard ones. What are so the indication? Anti-impingement, probably dual mobility is better than constraint, and anti-translation, dual mobility is less effective than constraint cup. Dual mobility cups have as 3 generations. The first one in the beginning of the 80s, then the second generation at the end of the last century, and then we have the third, the contemporary generation. The first generation gave very good results if we consider the rate of dislocation. No dislocation for Filippo. It was the first series of Bousquet, who invented the dual mobility cup. And then in Caen, in another city in France, when they use the dual mobility cup with a different stem, and we will see what the difference was exactly. And in case of revision for instability, the dislocation rate was close to 3% in comparison of usually more than 10% in this situation. And in primary, no dislocation for Filippo and only less than 1% for Lotrido in Caen, with a very, very good result at long term, because the survivorship was close to 80 to 90% at 15 or 17 years. But of course, there were some issues. And the most important one was the loosening, because the first generation used alumina for the fixation of the cementless cup on the bone. And of course, there were some wear of the rotative liner system with the first series of Bousquet, because, and you can see on the picture, that they use a stem with a very, very large neck, round, large, and rough. And that leads to a wear of the retentive liner system. But the real wear of the insert was very low, less than 10%, 2%, sorry. So what I described is the third articulation, not only two, like a dual mobility, but three articulation. The third one is between the insert and the neck, and it occurs in the maximum amplitude of movement. And when you have a wear of this part, you can have an intra-prosthetic dislocation, as shown in the first picture. This articulation depends on the diameter and the neck section. And for Bousquet, who used a very large neck, it was really an issue. In Caen, where they use only a charnless stem with a very thin neck and brilliant one, they had very less intraprosthetic dislocation. So this is the first message. When you use a dual mobility cup, you have to take care of the stem you use, and probably with a very good one. And I explained too with this schema that this contact between the insert and the neck must be considered about his geometry. And in the first generation, it was a point contact, not good. Now we use chamfers on the liners, and with the chamfers, the contact is a plain one, and then wear is less important. The second generation took the advantage of the first one about the mobility and the stability, but changed the fixation with a microstructure, with or without hydroxyapatite, and there were no alumina, of course, a stainless inox cup most of the time, with a press fit fixation or with screws and hook. And of course, the neck of the stems used was accurate, more or less finished, with a taper adapted. And it was the apparition of the creation about the sterilization of the insert in polyethylene with oxide of ethylene or gamma rays. Of course, there was some coating failure and mobilization of the implant, but it was proven that there were very low wear. Massin, in the Clinical Orthopedics in 2012, conclude that the fixation could be also improved, but the results were good. And these results were shown by the Symposium of the French Society of Orthopedy in 2009, about close to 2,500 cases with, on this schema, the survivorship of all the dual mobility cups, because it was a melting pot of dual mobility cups. And if we consider that the revision of the cup for aseptic, losing, or intraprosthetic dislocation was a failure, we can see that the survivorship was 95% at 10 years. You can say to me, but in the same times, the standard implants had better results. No, if we consider the Swedish register in 2019, the survivorship of the stems implanted before or after 2005, the results were equal, and the results was close to the previous ones I showed. It is 94%. Remember that with the dermatitis cup, we have 95%. So results were completely comparable. But of course, there is one difference. It's for very young patients. And you can see that with the standard cups, the results when the patient was under 50 years was less than 60% at 10 years of survival, meaning that for very young active patients, we have no real solution. And we can consider that the ceramics and ceramics results were comparable to dull mobility. And of course, with young patients, we have the same results with the mobility cup. On the red line, you can see that survivorship is, of course, less good for very active and young patients. But in the same time, explained before, in the Swedish register, we have the same risk of revision for very young patients. It is the purple line. So the mobility is proven to prevent dislocation in primary, and we can see that in the first generation, results were very good with a very long-term follow-up. But for all the generation, results are similar from 0 to 3% of dislocation according to the authors. The third generation, the contemporary one, has changed the design. Now we try to have a very hemispheric shape to avoid very important contact impingement between the neck and the shell, with a cobalt alloy to avoid any deformation of the shell into the bone, to avoid the blocking the insert, with a rotated eye covering insert in polyethylene to decrease the risk of intra-prosthetic dislocation, and with a press fit and with a roughness of the substrate with or without edoxyapatite or VPS porous titanium. Polyethylene is gamma sterilized, we will see that, and with a very adapted stem, of course, about cone and neck. For this third generation, we have published some results comparing standard cups at 10 years and a dual mobility cup, the Quattro one, and we can see that the rate of dislocation is very different from 13% to 1%, and the risk of aseptic loosening is exactly the same. So we have better results against dislocation with the same longevity at 10 years between standard cups and dual mobility one. And now we are leading a prospective study with a Quattro registry. Quattro is a one dual mobility cup with patients enrolled from May 2012 with a prospective and continue series with 6 surgeons in 5 centers in 2 cities of France. We want to demonstrate that the dual mobility cup is effectively able to prevent dislocation with a very good outcome at long term. So from January 2012 to March 2019, we have enrolled more than 3,275 total hip arthroplasty with close to 3,000 patients. It is a classical population with a mean age at intervention of 73 years. Most of the time, it was a primary arthroplasty for osteoarthritis. We use most of the time a cementless cup, but some of these cups were cemented. So the demography is classical too, with 3% of deceased and only 1% of follow-up. We have to face of 15 cup revisions. Why? One partial revision for loosening on tomatis at 1 year, 2 global failure, stem and cup, 6 cup retrieval for not implant related, and 6 implant related with 2 infection. If we consider the type of dermatic cup between the cemented and the uncemented ones, we can see that we have more revision and more concerns with the quattro-cemented, but more than the half of them were used in revision. So of course, results are less good than in primary. And sorry, I didn't show the rate of dislocation, but the rate of dislocation was 0.2 for all the series. So what was the evolution of dislocations in France? At first, only 2 centers in Saint-Étienne and Caen used the first generation. And elsewhere, it was only for some cases of revision, fracture of the femoral neck, patients at risk of dislocation. And then, with the second generation, we use the age to indicate the durability cup after 70 years without any hesitation, between 55 to 70 years according to the life expectancy and instability risk, and before 55 years old, there was an hesitation. But now, today, it is according to the surgeons, and durability cup is used in France in 40% of primary, 70% of revision, and 80% in cases of neck fracture. And if we consider the risk of dislocation, the rate of dislocation in France for all the surgery performed in our country, from 2005 to 2014, we have a decrease from 9% to 6% of dislocation for, I repeat, all indications in primary, in case of neck fracture, in case of primary for osteoarthritis or osteonecrosis. And in the same time, if we compare the risk of revision, we can see that in France, the reason of revision is, of course, the same that in the registries: aseptic loosening, dislocation, infection, fracture, pain, but the rate of dislocation is really lower than in the registries. And at the end, dislocation is only the first reason of revision for all THA in France. It is close to the second reason in all the registries. So, of course, that's very good for dislocation. But what is new now about dual mobility? We have to refer to the work of Nevelos. Remember that I explained to you that when we increase the jump distance in only on the frontal plane, describing by Masse and Wagner, there is a decrease of instability. That's right, but of course, we have to consider it in 3D. And the posterior horizontal dislocation distance described by Nevelos is more important because it is the distance for the dislocation to the posterior part of the joint, or the anterior one in case of anterior approach, of course. And this PHDD increase with the each side, but depends also of the cup inclination angle. And we know that the position of the cup is very important. So that means that the PHDD depends not only on the system, but also of the cup design and also, of course, of the placement done by the surgeons. In the same time, if we consider the free room of the cups and, of course, of the dual mobility one, with the risk of impingement, we can see that if we consider some dermatic cups, hemispheric, subhemispheric, anatomic one, the ADM of Stryker, or modular duality one of Stryker 2, in comparison with the standard cups, about the abduction, there are very different results according to the design. And then for the flexion, that's exactly the same. We can see that the subhemispheric duality cup has the best results. right. That means that if we delay the contact between the neck and the shell, we delay the risk of dislocation. That introduced the notion of prosthetic impingement theorem of Nesloff's 2. Amplitus gives IROM, of course, but there is impingement. It is mandatory with training. So that's the reason why very young people, very active people, training people have a very high risk of wear and then have less good results about the survivorship. But this impingement is not only in case of total hip arthroplasty. Even in physiology, I imagine that ice hockey is not very common in India, of course, but it is a sport very popular in the Scandinavian countries or in Canada and United States of America. And the authors, Ross and Larson, showed that there is a high prevalence of anterior impingement of the femur with a CAM type, more in the goalies more than lateral than hockey players. And they show that the goalies, like butterfly, have most of the time dysplasia of the acetabulum. And that leads, of course, to another arthritis. So impingement is mandatory for very active patients. So now we have this PHDD and the PIFR, so the posterior horizontal distance and the range of motion. And we can see that it's completely different if between the standard cup, the subhemispheric dual mobility, the anatomic one, and the modular one. Of course, the most important range of motion is with the subhemispheric dual mobility, but the PHD is less good. With an anatomic one, we have a better PHDD, but of course, motion is less important. So shell size and eye size don't affect PHDD significantly, but increasing total head diameter increases PHDD. That's the reason why durability is better, like Masse Wagner showed in the past. And increasing roofing of cup increase PHDD. It is the retentiveness, the ability to keep the insert into the shell to avoid a classic dislocation. But PHDD and PIFR can't increase together. Truth is a medium term, of course, like in life, between anatomic and subhemispheric design. And subhemispheric design with an external reed can be used, and we can see that we can limit this rim, like in the schema you can see now. This rim, the extension rim, can be placed only in the situation, the location where dislocation can occur, and then we have no rim in the other parts of the shell to avoid any conflict with the psoas tendon, for example, or at the posterior part with the neck and with a risk of dislocation. So in summary, now we can say that dual mobility reached range of reason. It's an old proven concept, more than 50 years, with excellent results against dislocation in primary, in revision. But most of the time, the results are better when the reason of dislocation is impingement. There were some errors of the first generation due to the material, sometimes of the design, but not of the concept. And of course, now there is a high improvement of the cup parameters. So the mobility could be considered as a reasonable alternative for very active or sportive patient with a good offset, thin neck, no taper overhanging, with a correct stem positioning, of course, and a correct cup positioning also. When stability and mobility are primary, of course, we can choose the mobility, even if impingement is unavoidable, but to delay this contact, and because the polyethylene contact with an insert of the mobility is softer than on alumina, and with a ceramic and ceramic total hip arthroplasty, there is a risk of fracture of the alumine. So which wear is preferable? Polyethylene or metallions or ceramic debris? I do prefer polyethylene, of course. But the question you can ask is, how we shift the dislocation problem to a wear problem? We have led a study published in International Orthopedics in in vitro study comparing standard cups and dual mobility cups after 5 million of cycles. And we have seen that the wear of polyethylene is exactly the same between the cup standard and the cup dual mobility. All other parameters were exactly the same. So now the question is, highly cross-linked polyethylene is the solution maybe better than the standard polyethylene? Yes, but what is cross-linked polyethylene? It's a very vague definition done by Harris. It is due to a reduction from 50 to 100 grays with a process to eliminate free radicals. But what kind of behavior occurs during head infections? Can it withstand the stress of all three articulations? You remember the three: outer between the insert and the metal back shell, the inner between the head and the insert, and the collar, the rim of retention. And we have no published derivatives series with more than 5 years follow-up with a highly costly polyethylene. But there is another study done by Malatre, Rupi Barrow, and Vesgreen, published in the International Orthopedics 2, and they compare mobile insert with standard polyethylene and with highly cross-linked polyethylenes, annealed and remelted, with insert impacted, the head impacted into the insert, or not impacted. First reasons, if we compare the not impacted mobile insert without head, there are no cracks for all the series of standard polyethylene and cross-linked ones. When they impact head into the mobile insert, they show that there were 14 mobile inserts with crack, but without influence of polyethylene. Cracks occurred in all the polyethylene, standard one, annealed one, and remelted one. No difference between all of them. And then the impact, and they extract the head from the inner. And they compare the force used for that. And of course, the cracks. There was no significant difference of the median force used to impact or to extract the head from the insert. But with a median force extraction, with the remelted crosslink, they saw more cracks than with the annealed one. So we can only say that with crosslink and retaining rim, there is no more crack compared to conventional polyethylene during the impact of the femoral head. That's right. However, for the remelted cross-linked polyethylene, there was a partial loss of mobile intervention effect with cracks because they crossed the limit of elasticity and plastic deformation. So the deterioration of mechanical properties by means of altering the crystalline phase leads to a risk of dislocation, intra-prosthetic dislocation. So in vitro, crosslink is a very reliable alternative to standard polyethylene, but with caution with the remelted polyethylene. So annealed seems to be superior to remelted one. So in primary, now we can consider that dual mobility is no longer a fallback solution, a substitute for the metal polyethylene bearing. It's not a default option or a lesser evil. Results are equivalent of standard cups. It's a real primary option with ceramic on polyethylene, ceramic on ceramic, metal on metal maybe, or ceramic on polyethylene with dual mobility cup. It is an option you can use with no risk of bad results. So what are now the concerns? Fixation, no. It is ensured by press fit in Europe or screwed cups in North America with a proactive fixation topology. Edge, yes, but what does it mean? Now we have some people about 70 years old, for example, very active. So what does it mean? Where? It is too vague. Where this will on the insert of the rotation rim, and why? Because of the activity or because of the design of the diametric cup. So the new parameters of decision are risk type, activity, and needs of the patient. And if you have a very high risk of dislocation patient because he performs some sports with a very high risk of dislocation, because he do trekking in the mountains alone, because his work needs a very high range of motion, probably the mobility is better. So is this reasonable for almost all? Yes, if stability is the main objective, if the activity with high risk of dislocation, and if the maximum amplitudes are sought. Yes, it is reasonable to use it, and age is no longer the main criterion of choice. It is an option, like I said before, of ceramics resurfacing highly polyethylene. The risk of polyethylene where exists occurs, but it's the same that the other options. So dual mobility is not mandatory, of course, but reasonable. What to retain? The edge criterion is not the most relevant. If wear is a strong fear for you, do not operate. Remembering that polyethylene wear is well documented and easier to treat than ceramic fracture. Analyze the demands and needs of the patient. Very old, very weak, constant cup. Active at risk of dislocation, dual mobility cup. Request for a safe activity, dual mobility cup. High impact activity or large amplitude, dual mobility cup. Demand for optimal longevity, probably standard cup with ceramic on ceramic. If there are no exact requests from the patient, it is your choice. You have to choose for them the best solution, and always remember the consequence of a choice. So as explained before, in France, in 2016, we used the mobility cup in 40% of primary, 2/3 of revision, and probably 80% of femoral fracture. And to end this presentation, there are more and more new studies about the mobility cup, proving that it's a very interesting option. And the two countries who publish the more is, of course, France, but also USA, where the mobility cup is beginning to be used, now more than 5 years before, but there are some concerns about its use in America, probably due to the shell, because they want to use screws, and the mobility cup with screws is not the best one. I thank you for your attention.
Thank you very much, Fierra. It was very interesting. And a couple of questions from my end. And what is the most common femoral aid you use it for it? No, it is 22 mm or 20?
28.
28.
I use, yes, most of the time 28, because the head-neck ratio is better with than 28. When I use a very small cup, 46 millimeters, I use a 22, and for 48, it depends on the age of the patient. For very young people, I would use the 22, but most of the time it's 28 with a ceramic head.
Okay. What about the stem? You go for elliptical or cylindrical or trapezoidal? What kind of stem you prefer?
I perform two types of stems. For old people, I use a Charnley one, typical Charnley stem with a very thin neck. And for young people, so more than 2/3 of the patients, I use a cementless one, straight one. It's a PAVI system of Lepin. It is like the Corail system with a very, very buoyant, polished neck. And it's a very thin neck too, because it's very important. The type of stem is not important. It's the type of the neck, which is the most important.
Okay, good. And what are the tips and tricks you offer, like, while doing global? Recently, we have done one case the last 2.5 years, very good. And what are the tips and tricks you give for young surgeons in India?
First, yes, I would say that it's very important, even if the mobility cup is very active against dislocation, we have to place the geometry cups very correctly, like a standard one. Of course, it's a forgiveness cup, but if you don't place it like a standard one, you can have some impingement at the posterior or the anterior part. So we have to avoid any impingement. So we have to rim as usual, and then to place the cup, if possible, like anatomic one, to avoid any overhanging of the cup of the anterior wall or the posterior one. I think it's the most important. And then we have to take care of the intervention of the stem to avoid the same risk of impingement. But the most important concern is to say, put it like a standard cup, take care of the position, and then you will have a very good result.
Thank you, Fierra. The last question for today is, when patient comes for a primary hip replacement, what is your implant of choice? Whether you go for a dual mobility cup or you go for a standard channelist type?
No, my first choice is a dual mobility cup with a uncemented stem, of course. But when the patient asks me about longevity, and when I know he has not a very high activity, I can use a ceramic on ceramic bearing. But my first choice is uncemented stem with dual mobility cup and 28 head of ceramic.
Thank you very much, Pierre, for accepting your time and given a lot of inputs about dual mobility cup. And thank you very much for your valuable time. I know it's a weekend beginning from tomorrow onwards.
Yes. It's holiday now. Thank you very much. Thank you. I enjoyed your fest.
More than 200 participants have participated, and I have muted many people because it's causing disturbance. Even though it is disturbance in the beginning, it was a very nice session to have in the evening hours. Thank you very much, Fierra, for accepting our request for the webinar.
It was really a pleasure to be with you, and I hope that it was clear and useful. I hope so.
It's very crystal clear about the concepts, why the dual mobility cup was introduced, and what are the current indications and surgical technique and outcomes also. It is very happy to see the dislocation rate is quite lower when compared to the standard total hip replacement and high risk patients like high ASA grade and neuromuscular patients. And I thank all the participants to have this webinar. And if any questions are there, Mr. Fierra is always in touch with me, and he'll happy to clear the doubts. Thank you.
Okay.
Thank
you very much.
Thank you for joining today's uni. Thank you so much.
Thank you.
Thank you. Thank you all.